Hi, thank you so much. Thank you so much for giving me time to talk about our state maternal mortality review report. And first of all, thank you to those of you who are present who are on the maternal mortality review panel. Would you mind standing up so we can give you a round of applause? Okay, so I'm going to go over some background from the report, some key messages, data, and findings from the report, touch on the recommendations for the report, and then talk a little bit about applying the report recommendations to our work. So some overview and background information. So as we all know, we look at maternal mortality as really the tip of the iceberg of a much larger issue of maternal morbidity. At least 60,000 people every year in the US experience severe complications related to pregnancy and childbirth. And because of this, we understand that the work of maternal mortality review has a much larger impact on people's experiences of pregnancy and postpartum and also the life course. And so we look at the reverberating impact of this work and the work that all of you do. A little bit of background on our panel. So our panel is directed by a legislative mandate to conduct comprehensive reviews of maternal deaths in Washington state. The legislature established our panel in Washington state in 2016, and then in 2019 amended the law to make the panel permanent and strengthen its work. The panel itself, so during the period that we're going to be talking about that led up to the writing of this report, there were about 70 members on the panel, and there's actually a little over 80 currently. Not everybody comes to every review meeting. It's usually about 25 to 40 people to keep it manageable, but as you'll see, we have just a wealth of expertise and knowledge and experience. Members serve a voluntary term for 3 years, and many do reapply for subsequent terms. And this is just a word cloud of some and by no means all of the expertise areas represented on the panel. And talking to my colleagues in other states, maternal mortality review is something that happens throughout the US and beyond, but connected to the folks doing review in other states, we're honestly incredibly lucky in Washington to have the panel members that we have. So how the cases are reviewed. The panel asks first, was this death related to pregnancy? And if it was pregnancy related, was it preventable? And something we do in Washington is ask not just, was this clinically preventable, was there a different medical choice that could have happened, but was this preventable from any type of equity and or social determinants of health perspective? And if a death was pregnancy related and preventable, we move on. We ask questions like whether racism, discrimination, and bias played a role, what factors contributed to the deaths, and then make recommendations that could have made a difference for each of those contributing factors. And so those recommendations based specifically on the deaths reviewed that were pregnancy related and preventable, those become the basis of the recommendations in the report every 3 years. So that's where they come from. So the report itself, it came out in February of 2023, and it covers deaths that took place in pregnancy through 1 year after the end of pregnancy. There's 2 time periods that are covered in the report. So data we look at cumulatively in our reports. So the data go back to 2014, which is when our first reports were, through 2020, which was the most recent deaths reviewed as of this report. But the recommendations are based on the deaths that were reviewed since the last report. And the last report came out in fall 2019, obviously a few months before things changed quite a lot in our world. So this report looks at deaths from that broader period and recommendations from 2017 through 2020, identifies things like inequities, disparities, and contributing factors, makes the recommendations, and then after me you'll be hearing from Cindy Gamble about the addendum to the report from the American Indian Health Commission. So key messages and data and findings from the report. So as we know, maternal mortality is a rare event. And because of that, observations from maternal mortalities in Washington aren't necessarily generalizable outside of the state. And, small numbers do make rates unstable, making it difficult to discern changes on a year-to-year basis. But still, despite all of that, we can make meaningful observations, recommendations, and interventions based on what we learn. So some of the questions people ask often, well, have rates in Washington increased? And overall, pregnancy-associated mortality in Washington state has remained relatively stable in recent years and didn't increase in the period of 2014 through 2020. However, and this is an enormous however, disparities persist. And people often ask, well, where do we stand compared to the national average? And Washington's maternal mortality rate is lower than the national average, but it's still unacceptable. So let's look at a little more data about these pieces. So I mentioned that overall the rate is stable, and that's the green line that you see on the top. The blue and the dark orange lines that add up to that below, the orange one shows which of those green deaths are pregnancy-related, and the blue shows which ones were not pregnancy-related. And you'll see over time in the years of this reporting, 2014 through 2020, a larger share of those overall deaths have been designated as pregnancy-related, which actually mostly reflects the panel's growing understanding of things like pregnancy-relatedness. So similarly, where we stand compared to the US overall, Washington had a rate of 15.9 pregnancy-related deaths per 100,000 live births, and in the most comparatively accurate way we could measure it, the US had a rate of 18.6 pregnancy-related deaths per 100,000 live births. But Washington's rate does include deaths from substance use, overdose, and suicide, and the US rate doesn't include deaths from any accidental or incidental causes. So that difference would probably even be more pronounced if they were measured in exactly the same way. The US had overall in this period 861 pregnancy-related deaths per year. Rates in the US have been increasing since the 1980s, and as many of us know, rates in the US are higher than in comparatively wealthy countries around the world. So preventability, one of the things that has stood out to people since we started talking about this report is that 80% of pregnancy-related deaths were preventable. 80%, that is an enormous percentage, and that is true. And preventable means that there was at least some chance of the death being averted if a factor that contributed to the death had been different. But what does that 80% actually reflect? It reflects a broader understanding of preventability. You remember when I talked about our process and I said we don't just ask if a death was preventable from a clinical perspective, but also an equity and social determinants of health perspective. That means since the 2019 report and this one, that percentage has grown because the panel understands preventability better. And we see this also reflected around the country as people get a much broader view of what it really means to be preventable. It also means we have an opportunity to take action because we know what are things that could have prevented deaths. Making those changes happen isn't always easy, but I see this 80% as a call to action and a reflection of understanding. And so here's what the 80% looks like in practice. So that number overall, 224, that's the number of total, like the umbrella category, pregnancy-associated deaths in 2014 through 2020, of which 97 of those deaths were pregnancy-related, and 78 of those pregnancy-related deaths were preventable. So that's the 80% that we're looking at, and that's what drives the recommendations. And so disparities persist, as I mentioned. Critical disparities persist by race and ethnicity, by socioeconomic status, by urban-rural status, and we better again understand these changes due to how the panel reviews the cases and also how we review data on communities with smaller population numbers, which is incredibly important. The panel identified some aspect of discrimination, bias, in either interpersonal racism or structural racism or both in nearly half of the preventable pregnancy-related deaths from 2017 through 2020. We also emphasize that communities that are most burdened by perinatal health inequities are the communities that have the expertise, the cultural knowledge to lead solutions to reduce maternal mortality. And particularly Black and Indigenous communities of people of color must be centered as leaders for the successful implementation of many of the recommendations in the report. So looking a little bit more closely at what the disparities look like, and I've put the page numbers for the report up here if you would like to look at these in more detail. So on the left we have the overall data for all maternal deaths, and on the right are the data for specifically the pregnancy-related deaths. And the blue bars are the rate per 100,000, and the orange is the frequency, or the actual number of deaths. And so right away, some disparities stand out, particularly under race and ethnicity, for American Indian and Alaska Native communities in particular, also Native Hawaiian or Pacific Islander communities and non-Hispanic Black communities. The disparities particularly stand out, especially when compared to non-Hispanic white communities. And again, that is not and should not be the baseline. The baseline should be no preventable maternal deaths. Also by insurance status, which is a reflection of socioeconomic status. Washingtonians on Medicaid had particularly high rates compared to Washingtonians with private insurance, for example, and that's a stand-in for socioeconomic status. Residents, although there were more deaths of urban residents, there are much higher rates for rural residents. So you see a lot of this reflected in the recommendations in the report and how we talk about it. So causes and impacts. So people often ask, well, what are the leading causes of maternal mortality in Washington? And we'll look at the data on this, but overall it's behavioral health conditions, and that's predominantly by suicide or overdose, as well as hemorrhage and infection. The report also includes 2020 deaths, and so people ask, well, what was the impact of COVID-19 on maternal mortality in Washington? Do we know yet? And the numbers were so very small for 2020 for COVID deaths that we can't make conclusions specifically about the impact of COVID-19 itself on maternal mortality in Washington, but we do know that there are national data and global data about this. COVID cases also impacted recommendations in the report, and you'll also see how recommendations reflect the changes of the COVID era, so addressing things like provider shortages, for example. So here's how the data break out about the 3 leading causes of death, and you'll see what I mean. The behavioral health line on the bottom is the largest cause of death that the panel determined, and of those, suicide is the largest category, followed by overdose. People often ask, well, why do you look at deaths from pregnancy all the way through 1 year after the end of pregnancy? Isn't that long? And you'll see a lot of different versions of this graphic in the report showing when deaths took place during that time period. So this is the version for pregnancy-related preventable deaths. And you'll see that based on how long those time periods are, it's actually fairly evenly spread out. And you'll see that largest share happening in that later postpartum period. And when you break out specifically the behavioral health deaths, that's even more pronounced. You see a lot of those deaths in the later period postpartum, really emphasizing the importance of focusing on all these time periods. So let's talk about the recommendations. If I didn't say earlier, if you want a copy of the report, it is very easy to just Google, but you can scan that QR code and it'll bring the PDF right up on your phone. So while you're doing that, if you would like to, the recommendations, which are on pages 51 through 75 in the report, they're under 6 kind of what I call the umbrella recommendations, the priority recommendations. And under each of those are many, many recommendations, kind of sub-recommendations. So the report itself has over 100 recommendations in it. We are not going to see all of the recommendations on these slides today, thankfully. But in those 6 categories, we also divided the recommendations up by kind of who does what. So there are policy and budget recommendations for the legislature, there are recommendations for providers and facilities, there are recommendations for all types of agencies and organizations, including governmental, academic, community, professional associations, and there's recommendations for DOH ourselves. So the first of the 6 priority recommendations is about addressing racism, discrimination, bias, and stigma in perinatal care. And you'll remember we looked at the fact that nearly half of the cases had some aspect of discrimination, bias, racism, or stigma playing a role. And so this really stood out, and we placed this first in our list of recommendations intentionally. There are many recommendations under this category, but a couple of them are things like expanding and diversifying the perinatal workforce to reflect cultures and languages of communities, or prioritizing access to perinatal care in communities experiencing inequities and disparities. The second priority recommendation is about behavioral health. So this one is increasing access to mental health and substance use disorder prevention, screening, and treatment for pregnant and parenting people. And there's a lot of recommendations in here around things like stigma, around things like screening. You'll recall behavioral health was the largest cause of death for maternal mortality in this report. So a couple example recommendations under that are things like increasing the number of residential treatment facilities where parents and children can actually be together, and improving screening for mental health, for substance use disorder, for suicide risk, things like enhancing reimbursement for screening, or screening all patients at admission with referral to services, treatment plans, telehealth services, or specialty consultation. The third recommendation, this is about healthcare access, which played a role in, if I recall correctly, I think about a third of the cases. I'll double check my notes on that. But this is expanding equitable and high quality healthcare by improving care integration, expanding telehealth services, and increasing reimbursement. So this is things like expanding home visiting services for pregnant and postpartum families, supporting legislation to increase access to doulas and midwives through 1 year postpartum, and funding rural hospitals and tribal clinics to provide obstetric care. So if that one was on healthcare access, the fourth one is on perinatal healthcare quality. So this is about strengthening the quality and availability of perinatal clinical and emergency care that's comprehensive, coordinated, culturally appropriate, and adequately staffed. So some of them, again, there's many recommendations under this one, like with all of these, but some examples are things like strengthening coordination of care by creating multidisciplinary care teams, or training providers, including emergency physicians, on how to coordinate with obstetricians to respond to obstetric emergencies. The fifth one is around basic needs, and if I recall, about a third of the cases review, the preventable pregnancy-related cases, access to basic needs was an issue. And so this recommendation is to meet basic needs of pregnant and parenting people by prioritizing access to housing, nutrition, income, transportation, childcare, care navigation, and culturally relevant support services. We all know all this work is intersectional, and meeting basic needs is so important for people's experience during pregnancy and postpartum, and also can help save their lives. So recommendations under this include things like increasing access to safe, affordable, and stable housing, and increasing availability of social workers and nurses to support patients, provide referrals, and then connect patients with support. And then the final recommendation is about violence prevention. And I believe 15% of the cases, intimate partner violence played a role to some extent, whether those were homicide deaths or other cases in which this played a role. So this priority recommendation is to prevent violence in the perinatal period through survivor-centered and culturally appropriate coordinated services. So things like increasing funding for resources to support survivors, safe housing for pregnant and postpartum people, free legal services for families dealing with intimate partner violence, and then also ensuring universal screening for interpersonal violence and personal safety. So implementation and next steps. My colleague who leads the implementation work has just returned from parental leave, and we're having some conversations about what comes next on DOH's end. But you'll remember I showed you that slide that only a fraction of the recommendations are for DOH specifically, and these are really recommendations for all of us in Washington and to support our existing work. These are some of the projects that have been put in place in the past with many different partners working on them in response to recommendations from past maternal mortality reports, and a lot of this work continues. And there's work obviously like perinatal quality collaboratives both at the local and state level. But I want you to also think about how do the recommendations connect to your work and your priorities and your vision. Which are most relevant in your region, in your field of work, or into things that maybe have happened recently. You know, we sometimes get questions saying, well, what about this event that took place a couple months ago? Why aren't there recommendations specifically about that? But as you saw, the recommendations are specifically tied to cases through 2020. However, they are often very relevant to things that have happened even more recently. Are you involved in efforts to implement one of the recommendations? Do you want other people to know about that and collaborate with you? Are there folks you're hoping to collaborate with to support in their efforts, to bolster their efforts? Are there efforts you hope to start soon? What about the coming legislative session? And basically, how can the findings and recommendations support your work and priorities? And I think of things like, if you're writing a grant or making a case for something you're passionate about, can you point to something in the report to support what your work is and further your work? So think about that. I'm always happy to have conversations about how this report can support your work. And I believe, and we're going to take questions together after this, so I will stop there, but thank you so much.